But I would just say, for anyone listening, I would just say, just know that the people on the other side of this work really do care about you. We really are doing the best that we possibly can. And I think that we're all just human beings taking care of other humans. And the more that we can connect, respect, and appreciate one another and support one another, the better it's going to be for all of us.
Welcome to the Medical Trauma Support Podcast, the show where we shine a light on the hidden impacts of medical trauma, explore tools for healing, and empower you to take control of your health journey. I'm Sarah, your host, a passionate advocate for trauma-informed care, somatic healing, and compassionate conversations. I'll bring you expert insights, healing strategies, and personal stories of resilience to help you feel seen, heard, and supported on your path to recovery. Hello, everyone, and welcome back to the Medical Trauma Support Podcast. I have been so excited for this episode because we have Dr. Laura Vater with us. Welcome.
Hi, Sarah. Thank you so much for
Hi.
having me.
Yeah, and I just want to tell the listeners that I've been following you for years on Instagram because I just love what you have to say about the system and, how we're all humans in this system. So I was hoping you would tell us a little bit about yourself and what got you into medicine and what also got you to the point in medicine where you are advocating for other people within the medical system and really kind of talking about the system and things that could be improved.
Well, thank you again, Sarah, for having me. Thanks for everyone listening in today. Sarah, you're doing such important work. I'm a medical oncologist, so in my practice, I take care of patients with cancers of the gastrointestinal tract. So those are patients often that have pancreatic cancer, colorectal cancer, liver cancer, stomach cancer. So oftentimes the work that I do is emotionally challenging, and yet I'm walking alongside patients that are dealing with really, really, really hard things. So I'm an internal medicine doctor, board certified in internal medicine and medical oncology. I also run a young onset program for patients diagnosed with these cancers younger than age 50. I also am a writer, so I write in terms of narrative medicine fiction. I run a narrative medicine program here at Indiana University School of Medicine. I teach, and I get to do a lot of other wonderful things. You asked why am I kind of, it's kind of interesting, right? How for each one of us, what are the things in our lives that bring us to the roles that we find ourselves in? When I grew up in a small town, and I had this lovely volleyball coach named Kim, and she was my coach since fourth grade. I mean, she was not married. She didn't have kids of her own. Her team, we were like her kids in many ways. So she was our coach, and she just kept coaching us throughout the years, all the way through high school. And when I was 16, she was diagnosed with advanced colorectal cancer. The diagnosis was delayed. She kept being told she had a urinary tract infection. She was having all of these symptoms. And eventually it led to this really devastating diagnosis when she was just in her early 40s. So very young and diagnosed with a very devastating cancer. Even at that point in my life, she knew I was interested in medicine. And she was the type of friend that would, we'd travel and she would come to Thanksgiving dinner and, of course, this coach. And so she said, you know what? Why don't you observe my surgery? And why don't you come to my appointments? And it became this, right? I was a teenager at this time. So it was this very formative season of my life. And I got to be a witness to many of the things that she was experiencing. Then I went to college. She's really the one that encouraged me to, all my friends were going to, great colleges. And they said, she said, you should go to Notre Dame. You're going to be the only person there that but you should take a chance and, go. And so she really encouraged me in that. And so I did. And so I was, she was just such a great mentor and friend to me. And she was receiving treatment all the way, through my sophomore year. And that's when she started not doing as well. And then she actually faced the end of life when I was a sophomore in college. I remember going home and visiting her in the end and being there holding her hand. And, her family has always, even now, her mom will send me cards. And I mean, I was a sophomore in college when she passed away. And it was just this really very hard thing in my life, but also this very formative thing. And so there are many things that kind of confirmed why oncology to me throughout my career. Taking care of patients, being at the bedside. But really, ultimately, I think it was really Kim and that first experience that now, many, many, many years later, 20 years later, I'm taking care of patients that have young early onset colorectal and GI cancer. So in many ways, it feels like I'm taking care of patients like him every day,
Yes.
who are facing very similar things. So that's the why. And part of my career has really been it's been partially my experience kind of going through medical training. My mother is a primary care doctor, witnessing her practice in a small town, seeing what those strains have looked like in her real life, seeing so many patients a day because that's the demands of either not having enough doctors or demands to try to make you know, you don't make money, or you get all these external burdens of the more patients you see, that's the only way you can keep a clinic afloat. And that's what a lot of doctors are told, right, is that you need to see more patients, you need to see them quicker. So I grew up, my mom went to med school when I was 9, watched her go through medical training. I've
How
still
cool.
witness her, come home at 8 or 9 o'clock at night, chart until midnight, fall asleep on the couch, wake up, just these demands of trying to take really good care of people. But the
Yeah.
challenge of that is being often overburdened. And then in my own training of experiencing really severe sleep deprivation, sometimes awake for 100 hours or more, having visual hallucinations to the point where I was having suicidal ideation, never had experienced this before. So having this calling, I'll call it, right, this vocation that I really felt that this is how I want to spend my life, but also facing these extreme physical and emotional, psychological challenges, just trying to get where I wanted to be to take good care of people. And so all of those things, long story short, essentially these pieces together have really made me who I am, what I like to think of as an advocate for both the patient as a human being, a person with unique features experiencing, oftentimes the most difficult, vulnerable thing in their life, and their family members experiencing that with them. And yet at the same time, this clinician that's trying to maybe they're holding sleep deprivation or being double or triple booked, or, working 80 or 90 hours a week, maybe facing their own physical or mental health challenges,
Right.
right? All this put together in a system of how in the world can we make medical care a place where two people are meeting together, two human beings, right? And that there can be connection and compassion and good care being given. So, anyway, that's a lot there, I know, but that's really what has kind of led me to the work that I do now.
I mean, this is why I'm so excited to have you on this podcast, because these are things that I think about all the time. I think about, just like you said, two humans coming together, right? So you've got a medical provider or clinician, and you've got a person who is oftentimes in the scariest, most vulnerable place they've ever been in their lives. And this feeling of not having control, right? Like it's so layered, right? What it's like to get a diagnosis, or to have an unexpected health crisis. And so, yeah, I think a lot about that human aspect. And one of the things that you often talk about, like publicly, is about the system, like you said, and the system that is keeping people up for 100 hours. Like that's forgetting that you're a human. It's almost like this expectation that you're superhuman and you're a robot. And so I think a lot about that. And I think about when somebody hasn't had sleep and they haven't had rest and they haven't had a chance to regulate their nervous system. Nobody who's been awake 100 hours is able to come in with a calm, regulated nervous system and attune to a patient.
There's some data to really back that up. Dr.
Mm.
Matthew Walker, who wrote the book Why We Sleep, he has a PhD. He's one of the top sleep researchers. He and his team did a study that looked at MRI scans of a person's brain, essentially after a night of no sleep, and they found that what they described as the empathy areas of the brain had significant less function when a person had been sleep deprived. Right. And we know this, that people, when we do daylight savings time and you have to, jump forward, spring forward, so to speak. So the whole country is an hour less without sleep. Philanthropic donations go down significantly. We know that when a doctor is low on sleep, they've actually done a study that they feel less compassion for a person's pain, and they're less likely to actually prescribe pain medicine. So there truly is a link here between sleep deprivation and compassion. And I think that if we ignore that, if we continue in the current medical system, which truly allows doctors to train and practice sometimes on very, very little sleep, then we, in another way, we're setting patients up to possibly find themselves in a healthcare system in which the clinicians around them are barely surviving, just trying to do their best. They may not recognize it, but they may have a physiologic depletion of
Yes.
empathy. And that significantly can impact a person.
Absolutely. I've talked to hundreds of people about their medical trauma stories. And, oftentimes that's a piece of it, right? Is somebody who didn't have the bandwidth to show up with the empathy and the compassion. Something that's always like stood out to me as people share their stories, a lot of times that's the part they're sharing that has impacted them just as much, if not more, than the medical thing that happened. It's how the humans that they're engaging with are treating them, listening to them, believing them. And when you talked about the empathy and the pain relief, that is something that comes up often, is people not being believed about their pain. So I think this is so important. And I love that you're doing the work inside the system, right? You're like outspoken about it. And I'm curious what some of the things are that you've seen shift a little bit, or what are some things you're working on, and what are ways that like we can help? Like, how can patients and how can listeners to this podcast help improve the system?
Yes, well, I would say thank you for caring. I think that as a clinician, and that term kind of represents a physician, nurse practitioner, physician's assistant, a nurse at the bedside, right? That term clinician really represents people that help provide medical care. I think clinicians want to be seen as human beings and need to be appreciated. So right now we are, as many people that are listening to this, we're facing just a dire nursing shortage. What happens is that nurses are often expected, and there are not enough that are hired for a shift. So let's say you're in the hospital and you're taking care of a loved one, and the person that you're sitting beside, they're in pain, and so you push a button and you wonder, okay, why has 10 minutes passed? Why has no one come? Why have 20 minutes passed? Does no one care? Okay, where are they? Okay, so that's what it feels like to be a patient when you have a need. I need to go to the bathroom. I'm in pain. I'm throwing up. There's something going on, and
Yeah.
no one is responding. The other side of that looks like perhaps there are only three nurses on that floor when there should have been six or seven, right? So that single nurse, she is taking care of six or seven patients at a time. Maybe a patient had a fall, right? Maybe someone had to be transported down for a CT scan. Those nurses are doing everything they possibly can. But what happens then is that they are run ragged and they're exhausted, and they're just, it's like, if for any of us, if we had to do double the amount of work we had to do in a single day for whatever work it is that we do day to day, we would be overwhelmed and we may not be as competent in that. And the same is true of physicians. If you're double or triple booked and you're expected to see more, take care of more patients or more needs than is humanly possible. But the
Yeah.
challenge to that is that many patients don't often see that or know that. And so they come, and rightfully so, come with this expectation of having, we all deserve this high quality, compassionate care in the moment that we need that. But oftentimes that is unfortunately just not the reality of the healthcare system as it is today. And so I would say what can we do, whether we're clinicians or non-clinicians, is first of all to recognize that there is a dire shortage of both physicians, and there's challenges of staffing within the hospitals among nurses. This is true of social workers. This is true of all healthcare professions, especially with an aging population. And so I would just say, as much as possible, even when you feel like, hey, I wish that I had support here, doing everything you can to say, oh my gosh, I know that you're busy. Thank you so much. I recognize you as a human being. So acknowledging their humanity as well, I
Yeah.
think, is a first step of someone just showing up to work. And sometimes even I'm surprised if a patient, if I sit down and so I say, how are you? How are you feeling? How are treatments going? And they stop and they say, well, how are you, Dr. Vater? And I'm like, wait, what are you doing asking about me? Right. And so I think part of it is just recognizing that we're all humans in this system. I truly believe that the people that are doing this work are doing it for a reason. Now, they may have forgotten about that reason. They may be so burned out, or they may be in a place where they have lost touch with that. They may be so sleep deprived or burned out that they may not be able to remember why is it that what drove them into nursing school or medical school or into social work. But as much as we can acknowledge their humanity, to appreciate them, and then to continue in whatever ways we possibly can to advocate for adequate staffing and support
Yes.
for our clinicians. The other piece of this is medical training. And I think that many people are, even if they're in a community hospital, you are going to be interacting with resident doctors, right? Fellow doctors, doctors in training. That name can be an intern or a resident or a fellow, but just recognizing that they're still in training, but they oftentimes are providing a huge majority of medical care, especially in underserved areas. So
Mhm.
recognizing that, they may have, when you're meeting them at 6 a.m., they've probably been awake for 30 hours, and they've probably, they've probably not had a second to even eat. They may not have had time to go to the bathroom in 8 hours. They certainly haven't had time to rest. And so I think there's a huge flaw in that, because it's really hard to
Yes.
provide good medical care in that setting. But just acknowledging that the doctors in the hospital, they've probably also been on call all night. If it's their turn, that means that they're covering the hospital. They're also on call all night, probably all week. And so I think there are a lot of flaws in the system, but just a simple
Yeah.
recognition of each other's humanity, I think, can go a long way.
Yeah, I think that's beautiful, and that's not hard to do. I mean, if you're really struggling and you're sick and you're in pain, that's a different thing, but I'm also curious about the system. Like, and I know that's a big task, right? But like, how do we make changes in the system?
Great question. If you figure that out, please let me know, because it is, honestly, it's a complex, often inefficient. We do a lot of things well in our healthcare system, but we also have a lot of inefficiencies and complexities and challenges. Over the last 2 decades, there's been an increasing push, just the way that healthcare is funded, there's been an increasing push for more efficiency. And nearly all of the essentially gains in efficiency have been on the backs of healthcare workers. So that has been, the support staff, that has even been the administrators within healthcare, that's been doctors, nurses, right? It's this ongoing push to do more with less, right? And I don't think that that's changing. The reasons for that are very complex. Partially, it's the way that healthcare is reimbursed, which has changed over time. Partially, it's because of an aging population and lower accessibility to doctors in some areas. So there are many challenges within that. I think that things that you can do is to, if at all possible, if you find a good primary care doctor, that's like gold, right? So get your preventive testing, as much as possible, manage your conditions as much as you can in advance, have a good structure in place, good relationships in place, so that if crisis strikes, which it will for all of us, right, at some
Hmm.
point in our lives,
Right.
that there are at least structures in place that we have already developed. And the hardest thing sometimes for many of my patients is that they're having symptoms and they feel like no one's listening to them, or they feel like they're being passed around, or they don't have a good working relationship with their clinician. I think that that can be one way that when you're facing some type of crisis, it can make a little bit easier for both the clinician who knows the patient well and for the person that's experiencing that. But of course, not everyone has access to that.
Right. Right. Yeah. And one thing that I'm very happy about and I talk about is I have found a place in Austin that is so phenomenal. I'm like, what is happening in this system that my primary care can sit with me for an hour?
Wow.
What is happening? Because I know, I'm like, if it can happen there, how do we make it happen in other places? I've been, trying to figure out medical trauma and learn about it and figure out how to support people in it and support myself and my family for years. And so part of that journey has been starting to find the trauma informed. That's the phrase I use that some people understand and some people are like, do you mean a therapist? I'm like, no, like, so part of my journey has been looking for places that are trauma informed, it's just such a different experience. But like you were talking about, if a system isn't taking care of the people in it and giving them the time they need, how are they going to show up in that way? And so that's a big question for me of like, well, what can we do so that all the places can do this? All the places can support their medical providers, their clinicians, so that they're able to show up and have time and have empathy.
Right. And I think a lot of that comes down to how are clinicians reimbursed? There are many clinicians that I know, of course, that work in multiple different systems across the country that are repeatedly told, if you don't work more nights, mornings, weekends, double book, triple book, you can't stay in our practice.
Wow.
Right? We just cannot keep our doors open because our reimbursements are so low. And it's even more challenging for the clinicians that are taking care of patients that are on Medicaid. And I think that, or that, are underinsured or uninsured. So this becomes increasingly challenging, that they want, deep down, they really want and wish that they had even a good solid 20 minutes with each patient. But the reality is they may be booked triple or double booked for a single 15-minute slot. And that is kind of what they're told is the only way that they can keep their doors open. And so they face this kind of conundrum. Do I work as hard as I possibly can so that I may not be able to provide the quality of care that I wish I could, or this clinic will not stay open. And I think that's a really challenging position that a lot of clinicians have faced and continue to face.
Yeah.
So I don't think that there are easy answers here. I appreciate that we're, having this conversation, and this is happening all across the world. I have friends that work for the NHS system in the UK, and they face similar kind of productivity demands, or what we call RVU based pay, right, sometimes. And I would anticipate that your clinician, your primary care clinician, is probably not compensated based on how quickly they can see patients, which is such a gift, right? Just
Yes.
be able to say, what I truly believe is that it takes the time that it needs to take, right? It needs to, whatever is happening. So even yesterday, I sat with a very young woman that was in a very similar situation, actually, to my good dear friend Kim, that is faced with colon cancer at a very early age, and her chemotherapy is not working as well as we want. And I'm sharing that news with her. And right in that moment, how do we, as clinicians, how do we share bad news? How do we sit with a person when they need it? And as a patient, what do we wish that a person might do? In my mind, I think that looks like sitting down, putting away distractions, including not being on the computer, on my phone, being as honest and kind as I can be in that moment, and then, providing support. And that support looks different on how well I know that patient. It might be, putting my hand on her shoulder and crying with her. It might be if she feels, talking about the next steps that I have prepared for her, the support that I'm going to give her. And sometimes it's just sitting together in silence and reminding her that she's not alone. And I think that looks different in different encounters, but that's not something that you can rush through. It's not something you can just say, okay, here's what we're dealing with, and I'm out the door. And I think that deep down, all clinicians wish that they had that type of time, that amount of time. And I'm grateful that I do. I'm grateful that I am in a type of practice where I can allow things to take the time that they need to take.
Yeah.
If you're on the other side of that conversation, like I like to think about, I've been in situations as, a pregnant woman and things where I've been told bad news, and it just destroys you, right? I mean, I don't know if that's the best word, but I mean, it is just devastating. And so I think to really think about, what type of care would we want for our family members, for ourselves, and then
Yeah.
trying to replicate that as much as we can.
Yeah, and that kind of takes me into, obviously the work you're doing, like you've shared, you're sitting with people in really, really hard moments and their families. And, you talked a little bit about being with them and holding space for them, but what about when you have somebody who has come in who has a history of medical trauma? What does that look like for you? Because yeah, I know that brings in an extra kind of layer of history that can be challenging for certainly for the patient and possibly for you as you navigate supporting them.
Yes. Yeah. So I have some of my patients, of course, I always want to protect my patient's identity, even in, conversations like this. I have a patient who had a very long hospitalization as a child for not cancer, but for an unrelated reason, who was in a children's hospital for almost 2 years. And this was decades ago, and now diagnosed with an advanced cancer. And from the moment that we met, he had all sorts of uncertainties about if he would want any treatment at all because of
Yeah.
the things that he had faced. And we met a number of times before he made a decision. So the first time we met, it was almost as if this couldn't be happening. Like, it was very surreal. and he didn't feel comfortable making any decisions in that moment. And he made very particular decisions, trying to avoid a port, which is a catheter under the skin, choosing some chemotherapy over others. And we've kind of walked through this as gently as we possibly can. That has been my approach, is to try to meet patients where they are, to invite them to tell me about those experiences if they feel comfortable, but not to push that if they don't feel comfortable. And then sharing what our options might be in as kind and gentle a way as possible, and then trying to sort through those decisions together. I also have patients who develop medical trauma as they're going through cancer treatment. So I had a patient who, even as they were cleaning her skin to access her port, the smell alone, it's almost, sometimes she would just be like, I have to leave. And so she would just leave the facility. It was just too overwhelming. And so she came to me from a different oncologist, and she didn't always, I was very, with her, she could get chemo when she wanted to, but it wasn't like, sometimes clinicians feel like, oh, if they're not adhering to this exact schedule or this exact structure and whatnot, then they feel as if they can't be treated there. Or, I have found that just trying to meet patients where they are and to recognize that there are a number of factors going on, helping ensure that as much as possible they have support. We have all sorts of layers of extra support in my clinic, my social work team. I have a psychologist, I have a psychiatrist, I have a dietitian, I have, a pharmacist. I have all these people that help support patients alongside me, which is wonderful. And a chaplain, they all bring additional skills. And I've found that that's been really helpful as well, to reach out to my other team members for support, but ultimately to try to, as much as I can, to meet that person where they are and discuss what might be the best possible path forward, and then to make that decision together.
Yes, that's so beautiful. And, it's funny, just in my peer group this morning, we were talking about how wonderful it would be if there were, within the hospital or within the clinic, there was mental health care, because that's not the case in a lot of places. And so let's say that somebody has just gotten a really upsetting news, and you've spent time sitting with them, but they really need more time. They need a lot of support around the emotional impact of a diagnosis. That you have a psychiatrist, you have a therapist, you have these different resources for them. And that's like the dream, right? That's the dream, that every patient has access to the support around their emotions and their mental health within health systems, because our mental health is our health. It's all our health, right? Whether it's a broken bone or fear and anxiety that's coming up around what a diagnosis is.
Absolutely. And some of my patients too, they are diagnosed and they almost tell me it feels like this train where they're just like on the train, and it's going fast, and they're just showing up for their treatments, and it's just all happening so fast. But some of my patients actually experience that it's not until 6 or 9 months later, when they've been through things like chemotherapy and surgery and all of this, where things start to slow down a little bit, our visits have spaced out a little bit, where they're in remission, or that sometimes it's the first visit I see them, which may be a month or 2 or even 3 after they finish treatment, where everyone in their life is saying, oh, well, hooray, your cancer's gone. And you should be so grateful and you should be so happy, right? That's what sometimes their friends and their family are telling them. And yes, that may be a component of what they're feeling, but they're also just trying to process what in the world happened over the last year of their lives. And they may not have really had time to do that. And there's also this fear of the unknown, of what's ahead. Right. And so some of my patients, that's when, and it almost takes them by surprise. And they say, I thought that I was going to be in a different mental place by now. And they're not. And so that's when they need the support the most. And so for each person, it's different. But I think as clinicians, and even as people experiencing illness, that we should be aware that it may be at a different place in our journey, that we recognize the need for kind of processing through in a thorough way as much as we can.
Yeah. And I think that that's pretty common, that when people are in this like acute, you're in like a crisis stage, processing the emotions, that doesn't happen then for most people, right? It's like, all right, I have this oftentimes life-threatening illness. I'm going to do what I need to do. I'm going to get through this thing. And then it's like, once, like you said, you're in remission, then all of the emotions that you did not have the capacity to process while you were in treatment are like, okay, and here, now it's time, and like you said, a lot of times that's when you don't have the support of the people around you because they're like, what? Snap out of it. Like, you're alive. You made it through this treatment. Hopefully they don't say snap out of it, but I know that some people do. And so, yeah, I just think, for people listening to really hear that, because there is nothing wrong with you if after your treatment and you are in remission, or, something that you'd been working on, medically is fixed. It's not unusual for the emotions to come up after you are through the original kind of like health crisis. And I think that's so important. I've talked to so many people who have had that experience. And I actually had someone on the podcast, Vanessa, who is a big advocate for spreading awareness for PICS. So the post-intensive care syndrome. And, she talks a lot about that experience of people who've gone through this acute situation. They've survived, oftentimes with like low odds of survival. So that's very scary in itself. And then they're alive and they're like, oh, okay. And the depression and the anxiety and all of these different things can start to come up at that time when they're getting less support than they were during the treatment phase.
Absolutely. And we know that PTSD, right, post-traumatic stress disorder, can happen from a critical care stay, and that's well documented. I think the other challenge too is that, many times, and I educate the learners that I have, medical students, residents, fellows, that when we take care of patients, and I do very often take care of patients who are in a critical care situation, so they have a breathing tube, they're on strong medications, they may seem like they're asleep, they may seem like they're sedated, but in truth, we know in retrospect that they can hear. Hearing is often, they can have some awareness. And so I really try to say to them, when you meet a person who is a breathing tube and on strong medication, introduce yourself, say hello, speak to them as if they were awake.
Yes.
And right. And if you're going to do a procedure, if you can, if it's not a life-threatening, this is an emergency, this has to happen now. And even if in an emergency, if you can speak it through, even better.
Yes.
If you can explain what you're doing as a clinician and doing it in a kind and gentle way, if you can, hold their hand, or if you can reduce their pain, or anything that you can do in that moment to, even in a very small way, to lessen that trauma that they may experience in that type of setting, then that's that. That might be something that in a very small way could help.
Yes, that is so beautiful, right? Like what a beautiful way to show up as a human supporting another human. And like you said, even if something is like an emergency, to talk through it, to talk as it's happening. So you're also still connected. They feel you there, right? I think, of somebody who may not be able to see or speak, but they're still there. And to know, like, your voice can be like a tether, right, to them, to know like that they're not alone in it. I just think that's really beautiful. And again, going back to the system makes it really challenging to have a lot of extra capacity or to have extra time. But there are little things that you're teaching your students that they can do, even that aren't going to take extra time, right? Like talking it through with somebody, letting them know you're there, introducing yourself.
And even little things, as something we talk about, that I speak about with my learners, and for any of your listeners who might be in a healthcare field, a healthcare worker, thinking about this as a career, having little things each day that remind you of your purpose. Why am I showing up in this capacity? It might be that as you're walking from your car into your clinic, you take a moment. If, you might just say, oh, there are people that I'm going to meet today or that I'm seeing again that need my care. Help me to be present, help me to show up for them as best as I possibly can. Maybe there's also, very simple things we do every day as clinicians, like wash your hands right outside of the room with hand sanitizer, or walk through even a door frame. Both of those things can be reminders to us to set aside whatever happened before, because that's a challenge we have as clinicians, right? Is something really difficult can have happened a moment before, and now we're stepping into a completely different situation. That's true in the critical care unit, that's true in the ER, that's even true in the oncology clinic. So as much as possible, using some type of reminder, a physical reminder like washing your hands or even a door frame, and to say there's a person on the other side of this door that is counting on me to be present. They're counting on me to pay attention, right? And so just in that moment, just as like a quick little reset. And that doesn't mean that you are ignoring the things that happened before. I think that as clinicians, something that can continue to help us connect with our patients is to really allow ourselves the time and the margins, right? There's this analogy of like when you're making a fire, you have the logs and the kindling, but you also have the air that flows in between. And that's the space in the margin. That's the time before and after work. That's time to sleep, hopefully to exercise, to have time with your loved ones. That time in the margin is really important for us as clinicians. And that should hopefully include some type of healthy way of processing. For me, that's journaling and writing. For me, that's also therapy. That also might be walking in nature, listening to music. That might be a ritual you have as you're driving home. But just to have some type of ritual that's reconnecting you with your humanity, processing through difficult things that may have happened that day. And many times as clinician, that is a handful of things all in the same day, right? But just to have some type of ritual, I think can allow you then to show up the next day rejuvenated and ready to serve again.
Yes. That's really beautiful. And I think the dream again, is that the system actually makes time for you to process it, and you get paid for the hour you go to see a therapist or, whatever it is. Like, how beautiful, right? Because the work that medical providers are doing every day is such important work. It's so impactful to people, and it serves all of us for the medical system to care for the people working in it. That serves every single human being.
Absolutely. If our clinicians are burned out, not only do they not, we know this, that they're not as able to do their jobs, either because they're short staffed and there's not enough hands for the work. They're facing a lack of compassion because of this exhaustion, or they're leaving the field altogether, right? Which puts additional strain on the people that remain. And so the more that we can support our healthcare workers, it can truly build a healthcare infrastructure that really supports patients as best as possible.
Yeah. This has been such a wonderful conversation with you. I'm so appreciative that you're sharing your time with me and letting the listeners hear this. This isn't information that people get to kind of see on the other side, right? As patients. So I really appreciate it. And I wanted to make space if there's anything you wanted to leave the listeners with. Maybe you have a book coming out, or maybe there's something, that you think is really important to leave people with before we end the podcast.
Well, hopefully one day I'll have a book coming out, but not yet. But I would just say, for anyone listening, I would just say, just know that the people on the other side of this work really do care about you. We really are doing the best that we possibly can. And I think that we're all just human beings taking care of other humans. And the more that we can connect, respect, and appreciate one another and support one another, the better it's going to be for all of us. Thank you so much for joining us for this conversation with Dr. Laura Vater. What a beautiful conversation I was able to have with her. So I wanted to let people know that are listening, if you are interested in finding a supportive community of other people healing from medical trauma, you can find out more about our Befriend Your Body community at medicaltraumasupport.com.